والصلاة والسلام على سيد المرسلين. I am Dr.Nasib Alshibli, General Surgeon Specialist working at Saudi Arabia, Al-Juf region. I have membership of Royal College of Surgeons in Ireland, certified by Arab Board for Health Specialization and Syrian Board for Health Specialization. We will talk today about something called wound healing and scarring. Actually, wound healing and scarring reconstruction, it is a major topic important for any surgeon candidate for MRCS examination. Many questions arise during this examinations, such as how do wound heal? We would know how to wound heal. What are the abnormal scarring? For example, hypertrophic scar, keloid scar. What factors influence the wound healing? What reconstructive letter? All these questions we should know, and all the answers about it after this concise presentation about wound healing. We don't want to go deep, just in brief. Normal wound healing has 3 phases. So wound healing has 3 normal phases. First of all, called inflammatory phase. Second, proliferative phase. The third is remodeling or maturational phase. First phase, inflammatory phase, lasts from 0 to 4 days. The proliferative phase lasts from 4 to 21 days, and the last one, or remodeling phase, lasts from 21 to 360, so up to 1 year. Let us start in inflammatory phase. It's very important to arrange your information. For example, start any insult or injury to the wound, to the skin. So injury to the skin cause what? Cause local bleeding. Local bleeding or hemorrhage is limited by something called vasoconstriction. Vasoconstriction mediated by thromboxane A2, prostaglandin 2 alpha, and adrenaline. So injury to the wound cause bleeding. Local bleeding is limited by vasoconstriction mediated by thromboxane, prostaglandin, and adrenaline. Collagen exposed and subsequent retracted or retraction of endothelial cells occur. That endothelial cells, when retracted, it activates clotting cascade and allows platelet to come into the wound to form platelet plug. We reach it to platelet. Platelets release something called platelet-derived growth factor, fibrinogen, and von Willebrand. All these factors stabilize the wound or stabilize the clot formation. So, another thing occur in the inflammatory phase is capillary vasodilatation. It is caused by numerous of enzymes such as histamine, bradykinin, nitric oxide, which all bring the inflammatory cells from the circulation to the site of injury. 2 sentences about nitric oxide just to know about, because it has some application in pharmacology. Nitric oxide, it is called, or it is known in the body as endothelial derived relaxing factor. So nitric oxide is endothelial derived relaxing factor. The vascular endothelium uses nitric oxide to signal the surrounding smooth muscles, so dilating, it will dilate, and blood flow increases. It is mainly synthesized by arginine and oxygen, so it is a key biological messenger in playing role in many things, such as vascular dilatation, as we told, neurotransmitter and hair cycle modulation and penile erection. It's also manufactured by macrophage and neutrophils, so it is toxic to bacteria. Has a role also in something called reperfusion injury after a period of ischemia. This is what should know about nitric oxide when it is mentioned. So nitric oxide and prostaglandin and histamine, bradykinin, all these mediators cause capillary vasodilatation, which brings the inflammatory cells to the injured site. 3 types of sites in the inflammatory phase you should know about. Neutrophils first, it is called a scavenger cells. So it is called a scavenger cells. So it scavenged or debrided the wound, kills the bacteria. It is toxic to the bacteria through opsonization or some mechanisms. Peak occurs at 24 hours after injury. Neutrophils peak occurs at 24 hours after injury only. Monocyte in the bloodstream, when enters the injured site or the tissue, it is called macrophage. Macrophage secretes numerous of mediators such as collagenase, elastase, tumor necrosis factor alpha, transforming growth factor beta, and we should know in the second phase what's their rules, and prostaglandin. So these mediators have a role in the proliferative phase, as we should know after some time. The third thing, or the third type of cells, is a lymphocyte, which enters at day 3 at the injured site or the wound site, enters the wound at day 3 and have a role in antibody production and cellular immunity. So this is, we can summarize as we summarize the inflammatory phase, started from injured site, cause local bleeding, limited by vasoconstriction, some mediators, and we are talking about step by step, starting from retraction of endothelial cells, clotting cascade activation, platelet secreted the mediators as we told, and the inflammatory cells. This is called the inflammatory cells. This is the most difficult phase to hear or to know about. The second phase, which lasts from 4 to 21 days, is called proliferative phase. Proliferative phase, 2 things you should know about or occur in this phase: angiogenesis and collagen deposition. To know them, you should remember 2 things. TNF-alpha, tumor necrosis factor alpha, which secreted by macrophage in the first phase, signals endothelial cells, and which migrate and new capillaries form. This is TNF-alpha. Transforming growth factor beta, which also secreted by macrophage, signals fibroblast for collagen deposition. So angiogenesis or new capillaries forms, and collagen deposition type 3 start to synthesize and continue to produce it until the day 21. Just to remember the collagen types, 4-5 types, you know. Type 1, it is found in the bone, tendon, skin. Type 2, such as I have remembered like this. Type 2, inhaling cartilage, it is found. Type 3 in the dermis, arteries. Type 4 in basement membrane, and type 5 in the cornea. So just to mention about the collagen. So the collagen type 3, which is deposited through the proliferative phase. Both angiogenesis and collagen deposition type 3 called granulation tissue. So granulation tissue, what? It is a newly formed connective tissue. newly formed connective tissue made up of capillaries, inflammatory cells, myofibroblasts, fibroblasts, many things. Two sentences about epithelialization. Epithelialization occur also in this phase. Epithelialization depends on what's the mechanism, or depends on the basement membrane is breached or not breached, intact or not intact. If the basement membrane is intact, the epithelial cells migrate upward in normal pattern, result in epithelialization in 2 to 3 days. This is fair. If the wound is in deeper wounds, if the basement membrane is breached, so the epithelial cells, one layer coming from the edge and the base, and result in epithelialization. And of course, structured skin structures such as hair follicles, sweat gland may produce a source of epithelial. So this is the proliferative phase. Angiogenesis, collagen deposition type 3, all this is called granulation tissue and epithelialization. The third and the last, or maturation phase, or remodeling phase, it is called exactly collagen recognition. The collagen type 3 is totally replaced by collagen type 1. So type 3 collagenase, which secreted by macrophage in inflammatory phase, start to degrade or break down the type 3 collagen, and myofibroblasts and fibroblasts start to synthesize a new collagen, which is called type 1 collagen. It is give the scar more strength, because vascularity decreases, water absorbed, collagen become cross-linked, so give the scar some strength. This is the remodeling phase. The type 3 collagen deposition totally replaced by type 1 collagen. As we are mentioned wound strength, we should know about wound strength. In both inflammatory phase and proliferative phase, the scar is loose and weak, little strength. At 6 weeks, as it is mentioned exactly in Sabiston, and at 6 weeks, the wound at 50% of final strength. So at 6 weeks after injury, the wound at 50% of final strength. Maximal strength, which is only 75%. Some books mentioned 80%. Maximal strength of the wound, which is only 75%, gained reached by the time from 6 to 12 months post-injury. This is wound strength in brief. Any abnormality in the proliferative phase, inflammatory phase, cause, or a remodeling cause some scarring or abnormal or aberration in the wound healing. The two things or two types of abnormal scarring we should know about and have to differentiate between them. First of them called hypertrophic scar, and the second keloid scar. We should now know everything about these two types. Both have the same definition: raised, red, thickened scar. So hypertrophic scar and keloid scar, by the definition, raised, red, thickened scar. In hypertrophic scar, it limits through the boundaries, or limits through the reach about abnormal scarring, which hypertrophic scar we have to know about, and keloid scar, and how to differentiate between them. Hypertrophic scar and keloid scar both have same definition: raised, red, thickened scar. Hypertrophic scar limits to the boundaries of the original wound, while keloid scar extends beyond the original scar, beyond the boundaries. This is the first definition, the first differentiation between them. The second thing, in hypertrophic scar, it occurs soon after injury. In keloid, occurs months after injury. This is the second. So two things: limits to the boundaries of the original wound in hypertrophic, extends beyond the boundaries of original wound or original scar in the keloid, occurs soon after injury in hypertrophic, or occurs months after injury in the keloid. Regarding the etiology, usually hypertrophic scar results from tension over tightening, suturing, and bronchial inflammatory phase. While in keloid scar, it is unknown or autoimmune phenomena. There are some theory. It is what occurs exactly. It's an imbalance between collagen degradation and collagen production. So it is an imbalance between collagen production and degradation. But the fibroblast number cells remain the same. So no increase in the fibroblast numbers, just the collagen increase. Another thing or another difference, this about regression. In hypertrophic scar, regression or there is some spontaneous regression over years. In the keloid, no regression. No regression. Another thing also, we can add dark skin, more susceptible, more prone to be affected by keloid, or more affected by, while in hypertrophic scar, it sometimes affecting some types of anatomical sites, for example, the shoulder, anterior midline, chest, such as this. So these about hypertrophic scar. And another thing, regarding the keloid, something only we forget about it, worsened by surgery and worsens in pregnancy, and no regression, as we told. What factors, for example, influence or affects the wound healing? We can many factors, but I have summarized it by two. It's made up of two things: something related to patient and something related to surgery. So patient factors include age first. Infants and elderly scar well. Second thing, anatomical site. Anatomical site, for example, or skin type. Skin type. Celtic people, it's some category from India migrate to the Europe. It's more prone to be affected in the, or to be affected by hypertrophic scar, while dark skin caused or affected by keloid. There are some concurrent morbidities, such as diabetes, malnutrition, all infection, all affecting the wound healing. This is according to patient factors. And there are some local also, such as previous radiotherapy, edema, vascular insufficiency, all these affecting, or all these factors related to the patient factors. Something important is to remember: age, anatomical site, skin type, and local and general, if we have to summarize them. Regarding the surgical factors which influence the wound healing, first of things, and we should concentrate about, atraumatic skin handling. For example, use non-tooth forceps rather than tooth forceps. This is atraumatic skin handling. Inversion, skin eversion, because inversion of the borders places keratinized epidermis, and it is a dead material between the two surfaces and would affect wound healing. Free tension free, suture free, suture also free, or should suturing should be tension free. Also, over tightening leads to necrosis, under tightening leads to gapping and opening the wound. Scar orientation, you should respect it. It should be parallel to the skin lines or skin crease. And let us talk about stitches. Stitches type, use always non-absorbable suture, because it causes least inflammation rather than absorbable suture. Stitch marks 7 days or less, no stitch marks 14 days or more. There are stitch marks between them. It's according to the local factors and anatomical site and wound type. Also, if we create an ellipse, the ellipse length should be 4 times the width to avoid dog ear. These are factors which influence the wound healing. Before we finish it, we should know about reconstruction letter, because if somebody asked what reconstruction letter, we should know what's the reconstruction letter. Let's start from allow to heal, primary healing or primary stitching, delayed primary stitching, tissue expansion, split thickness graft, full thickness graft, local flap, distant flap, free flap. This is a ladder. This is a systematic approach which creates to reconstruct the defect. So use as the ladder is descended, surgery more risky for the patient and becomes complex. So this reconstruction ladder uses simple procedure. So allow to heal, primary healing is better than delayed primary closure. As for example, local flap, which flap raised from flap raised in nearest to the defect, it's better than distant flap, which taken from distant area with vascular pedicle, and it is better than in normal wound healing, from distant free flap, which detached totally from the tissue from side of the body and re-anastomoted the pedicle. This should this topic should know only about wound healing. I think we are summarizing everything about wound healing, and we can repeat them as you want. Okay, thank you very much for listening.